Hello, hello, and welcome to the Feeding Pod. This is your host. I'm Brianna Millick, and I am a speech language pathologist and certified lactation counselor. I specialize in infant and medically complex feeding and primarily see patients in the home health setting, although I do have some that I see in outpatient or via telepractice. I'm also an instructor at the university level and a PhD student studying communication and information sciences. I have a huge passion for evidence-based practice and supporting information literacy in speech, language, hearing, feeding, swallowing sciences, specifically as it pertains to social media and translational research. This podcast is meant to share anything and everything related to being a pediatric feeding SLP, feeding therapist, with sprinkling in a little bit about working in academia, being a PhD student, and how to access, appraise, and implement research into clinical practice. Some episodes may contain guests, and I'm already looking forward to some of those coming up, while others might just be me rambling about something that's been on my mind. Regardless, my goal with this podcast is that you walk away not just with newfound knowledge, but with the inspiration to think critically and not be afraid of research. So without further ado, let's get into today's episode. Welcome back to the Feeding Pod. This is Bree, and today I am accompanied by Asha Bodycoat and Holly Tickner, who are speech and language therapists in Australia. And so I'm really excited for us to kind of talk about some of the differences between feeding therapy from one side of the pond to the other and talking about what that looks like, but also just how does feeding therapy also kind of come together in the same way, but also what's different in terms of not just practices, but maintaining certifications and things like thickeners and G-tubes and what some of those practices look like. So I'm really excited to have you all here. And I'm actually going to throw it over to you all to kind of just give a overview of like where you're practicing, what you're doing. Give me just like kind of a brief, who are you kind of thing.
Thank you. Can we start off by saying, I love the way you say Australia. That was beautiful.
Thank you.
Can you say it again?
Australia?
Yeah, it's so cute.
It's a real different vowel sound, isn't it?
It's lovely. It's really
Is it
nice.
a little bit of my southern accent coming in, or?
Maybe.
Yeah.
It's cute. Anyway,
Yeah.
I like it.
We
Thank
love
you.
it.
Makes it
you.
very broad suddenly with my accent.
Yeah.
Do you want to start, Asha?
Sure. I'm Asha. I am, well, we call ourselves speechies over here.
Love it.
Speech pathologist is the lingo officially, but colloquially we're speechies. We are based in Perth in Western Australia, and we work in feeding pretty exclusively, which we love. That's obviously both our areas of passion. So I'm based north of the river. It's a very Perth thing to say. Like, are you north of the river or south of the river? I grew up south of the river, but I made the move north, which is considered
contentious.
Yeah.
Contentious.
So I'm in a suburb called Kingsley, and I rent a clinic room at the moment from an OT practice up there. So I'm there a couple of days a week, and my clinical focus at the moment is mostly neurodivergent children. So across, I guess, toddler years through to early adolescence, and a few other things mixed in, kind of picky eaters and a few kind of dysphagia kids as well. But neurodivergence is my love.
Yeah, well, that makes sense that we're in the neurodiversity affirming feeding therapy course together.
Yeah. And I recently did some postgrad training in autism assessment and diagnosis. So this is like my two loves coming together. So I really love looking at autism as a neurotype broadly and how that impacts the experience of eating. So
awesome.
Yeah, that's me.
Awesome. All right, Holly.
Hi, I'm Holly, and I've been doing feeding for a little while. I was trying to work out, I want to hit that 20-year mark, but I don't think that's for like another year or two. So I would love to be able to just say, I've been doing this for 20 years because it's just such a nice round number. but I'm not quite there yet. I spent most of my career working at the Children's Hospital here in Perth. And as I don't know how you rank your seniority levels within hospitals, but I was the senior, which is like the top one for the NICU. Do you call it the NICU? Yes, I never know if the vowel is right, if it's going to translate, because like we call them premies, but you guys call them
preemies.
Pre.
Yeah, whereas ours is premies.
Spell it. Okay, how do you spell it though? Do you say
PREMMIES?
Yeah.
See, that's why, because ours is PREEMIE, which is why I always mess up the spelling, because I don't understand.
Where did the extra E come from?
That's a great question. I would love to answer that if I had the answer to it. I have no idea where this extra E comes in. But that's why it's pre instead of prem.
I guess like preterm.
Well, like, why do you, but why do you like spell pediatric with an A, you know?
Because of the Brits, my darling.
Yeah.
I know, but that's, it's, I don't know. I don't know where the because it's spelled premature with only one E.
You say premature, whereas we say premature. So right. I think it's just.
But our premature only has one E. So I don't know why it switches to two for the abbreviation. English is not like American English. Just I don't ask.
Yeah,
look, it's all good. Yeah, we don't. And all English generally.
Yes.
Don't ask questions about the spelling, do you?
No.
Yeah. So I worked in the senior for the NICU, and we had like an early intervention program for the under 2s, but I worked across like airway, voice, swallow clinics, and everything really, but medical. So I did that for quite a while, and a few years ago jumped out of tertiary hospital stuff into private practice in the community, and now I feel like I kind of work with the same kids actually. It's just that they're home now, they're not in hospital, and I suspect probably a similar caseload to you actually, Brie, from what I can gather. And I still really love it. I'm still doing it after all this time, so yeah.
Awesome.
Yeah. I work south of the river.
Okay.
So
okay, when you like north and south of the river though, like how big is Perth?
Perth is tiny. It's tiny.
Okay, so it's not like hours.
It's not a big deal.
It's expanding. So
it's such a Perth thing to say, like I work in the north. Like we honestly were a blip in the scheme of, like, I think our total population for Perth is 2 million people.
That is so many people.
Like new housing developments kind of go outwards. So we've got a lot of routes. It would take like, I don't know, sometimes I travel like an hour to see a client that is still in like the Perth area, I guess.
Okay, so it's pretty broad. I just like that just sounds like so many people for a singular area.
Probably for Western Australia, to be honest. It's probably not in Perth.
We've not done any fact checking.
I have not done fact checking on that. I should really do a quick Google on that one. I think what's worth pointing out to listeners is that, so we're based in Western Australia, and it's very big. It's a very, very big state.
Yeah.
It's the biggest out of all Australia, but Australia generally is very spread out. So I think like the state of Texas, again, I haven't fact checked this, but like the state of Texas fits like several times into the state of WA. Like we're a big, very spread out state. So to get to the top of our state, you would need to fly in an aeroplane. Like from Perth, we're kind of like not even at the bottom. You would need to fly in an aeroplane for a few hours.
Yeah.
To get
to the top. So it's almost it's almost like a small state. Because like South Carolina has like 5 million people. Texas has like 29 million. I mean, they have a lot more. So, okay, that makes a little bit more sense. But still, that is, but spread. So, okay, that's pretty far to travel for some patients if you're traveling like an hour sometimes to see a client. Okay.
I have a family that travels. They drive 8 hours to come and see me.
Oh yeah.
Yeah. So people will do the distance to get therapy.
Yeah. Wow.
Yeah.
Wow.
Yeah.
That is wild.
8 hours one way, I should add. It's 8
One
hours.
way.
And then they stay overnight, and then they'll drive back.
Where are they coming from?
Outside of Geraldton.
Okay. Yeah.
Wow.
Wow.
That's pretty far. That's pretty far.
Yeah.
Do you all offer, I'm assuming, but like, do you offer telepractice, or are there limitations in Australia you can? Okay.
Yeah, we do offer it. Some families don't have good access to coverage
Just
because
depends.
they're living we describe the families when they're living remotely.
Yeah.
So we have, like, you can live in a metro area at a city or a town, and then you might live rurally, so you're kind of in a country town, and then you might live remotely. And so some families, if they're out in like a big station, a big cattle station or something, they don't necessarily, they might be relying on satellite for their coverage, and so they don't always have good, reliable connections. And not all kids do great with telehealth or telepractice.
Agreed.
So
Agreed.
yeah, some families, that's just what they want to do. Or if they need to access a hospital, the only children's hospital is here in Perth. So even if you live a 3-day drive from Perth, if your kid needs to go to hospital for a procedure, this is where they have to come.
Yeah.
Wow. Very interesting. That's very.
I do have some telehealth clients from different states in Australia. So I think I have one in New South Wales at the moment. So we don't have licensing. I think you guys need a license to practice in a particular state, do you?
Yes. Yeah. So you have to be licensed in the state you're servicing. So I don't have to, for example, if I had a license, I live in South Carolina, but if I had a license in, say, Virginia, I could treat someone in Virginia, even if I'm in South Carolina, they just would have to be in that state. But if I don't hold the license there, I can't technically treat in that state. Now, there's kind of like a little bit of wiggle in terms of like, you can provide some consults or coaching. You just can't provide direct therapy for someone in a state that you're unlicensed in.
Okay.
How do you get a license?
You pay is basically you would pay for the license in that state. So there's certain criteria, like every state has slightly different criteria in what they require in terms of like keeping up with your continuing education or like just certain requirements of what you can and can't do. And so you would just have to follow that for every state. So for example, South Carolina, you couldn't do the initial evaluation virtually. So if you were going to see a patient, if someone didn't live in the state and they didn't do the initial eval in person, you can't see the patient virtually. You have to do the initial. But other states, you can do everything virtual. So like, that's kind of where it comes into play. Now there is what's called the interstate compact that's going around where states are signing off saying, hey, we will agree that like whatever your home state is, you pay a little extra there, and then you can treat in all the states that sign up for it. So that is expected to roll out this year. So there are some states that are signing up for that to say, because I mean, that just broadens access to care to so many people. It's truly just like, I feel like all it does is hurt the families and the kids by not allowing that. So there is like some works to make it happen, but there's just, all the like finances and politics and stuff that go behind the scenes of it that is kind of a barrier or making it move forward slowly.
So how common is it that a provider would have a license in more than one state?
Well, mostly because it's expensive. So like I pay, like almost $200 a year to have my license in my state. So if I was to pay that for 50 other states, it's not necessarily worth it for the patients that I would be seeing. So most of the time people are only paying for the state where majority of their patients are from. Because again, you can offer cash pay. So for example, if I've had a patient, for example, that lived in North Carolina, but I'm like kind of on the border. So they would drive an hour to see me in South Carolina. Even if they live in another state, as long as they come into the confines of South Carolina, I can see them. They just have to like be in the state.
Sure. Okay. So we can see telehealth, I believe, from any state. But if you do a certain amount of work where the client is in another state, you need to get a working with children check from that state. So all of our states and territories have their own working with children check, and that's a pretty standard thing that you have to have for anyone working with kids. So I believe I can see a few clients in different states, but as long as it's not the majority of my like month of working, I don't have to get there to have checks, which would be really tricky because I physically most likely would need to be in that state to get the check.
You need to present in person to hand in the documents.
So they just don't want you. Well, which I mean, like from as terrible as that sounds, but like from a business standpoint, like thinking of the state as a business, it makes sense. They don't want you taking majority of what they should, technically be receiving in funding. So yeah, it's definitely a lot more strict here in terms of like not being able to.
But I think you've touched on something interesting there about funding. Our funding, say for our kids who are accessing therapy, so we have what's called a national insurance scheme for kids with disabilities. And so that money is shared nationally across kids.
Oh, so it's not even state dependent.
It used to be.
That's what ours is. Ours is state dependent. And so that's, I think, one of the big reasons that they're hesitant, because the insurance won't cross states unless someone in another state provides something that anyone in your state doesn't provide.
Wow. Okay. All right. Yeah. No, we have a process that's it's really in its infancy of being rolled out, like the last, what would you say, like 6 or 7 years?
Yeah. It hasn't been around for very long in the scheme of things.
It's called the NDIS, National Disability Insurance Scheme. And the idea is that we work mainly in early intervention and school age, that you provide support and funding for children when they're young, and they should need less of it when they get older, which is, a
lovely idea.
Yeah, it's in an ideal world, that's how it works, but we know that's not the case. So what happens is basically a family would go through like an eligibility process to apply. And then if they are deemed eligible, they'd have a planning meeting. So like a delegate from the NDIS would sit down and go through a fairly functional assessment with them, gather evidence, and then they get given for the next 12 months or 24 months a dollar figure that they can use. And it's kind of broken down into different categories of supports. So our funding for our services would come out of a particular bucket. And basically, depending on how you choose to manage your funds, you can choose which provider you use it with. And there's a fair bit of flexibility in it. But sometimes it can be tricky balancing. Like, say you might have 3 or 4 different providers, and making sure that you've got enough over the year for everything you need. Sometimes that can be a little tricky. It's opened up a lot in terms of new services in the last few years. It's been crazy how the landscape has changed.
Actually, so how does a child get allocated funding through your insurance schemes? Like who signs off on it?
Yeah, it's interesting because that sounds very similar to our early intervention programs. However, our early intervention programs are state dependent. It's not nationally dependent. So the programs are for birth to 3, and it's the same concept, thinking if we support children during this developmental period, most likely they're not going to need as many services down the line. Now we know, of course, that's not the case for all children, but it really does help quite a lot of children. For many children, that's beneficial. So in the birth to 3 program, any child, regardless of financial status or diagnosis, can apply and get it for birth to 3. However, there is the process where they go through a developmental assessment. This is typically done with, again, depending on the state who does this. So in some states, it's what they would consider like the lead therapist, whether they think the child's primary need is communication or physical therapy or occupational therapy, they'll lead it. But in other states, for example, the state that I'm in, it's led by what's called an early interventionist. And so they just do a broad assessment on everything and determine what the child would need. And again, state dependent on what goes on. So for example, in the state of Kentucky right now, anyone who works in early intervention is not allowed to do feeding or swallowing. They want feeding and swallowing services, they have to go through private.
Wow.
Literally, it doesn't make any sense to me. Like I don't understand, but like that's one of their rules
Right.
is early intervention just
But-
doesn't cover like that
Like-
state was just like, you know what, actually no. And they used to, and they took it away. And so they're
You
like,
know what? We almost had that happen here too.
Did we?
Yeah, with the NDIS, because they said that dysphagia, which was just like this all-encompassing term to capture anything to do with meal times, was a medical.
medical.
problem.
Oh yeah.
Yep.
So the hospital
Not developmental. Yes.
not developmental.
Yeah.
And so we had a big, huge amount of advocacy go into trying, well, successful, which was great. But yeah, our national like membership body, Speech Pathology Australia, did a lot of advocacy to get it back included in our
I mean, it's
disability inclusions.
so wild. But yeah, so that's like where it's very state dependent though, in terms of what it applies. But with that being said, as long as I can vouch for why a child needs a certain amount of therapy or whatever, they will cover it. So there's not necessarily like a budget in terms, as long as I can justify why they need as much as they do. And then once a child turns 3, if they still qualify, and qualifications again, state dependent. For some states, it's like a severe delay in one domain. In some, it's like 2 domains have to show there's different criteria, and they can continue the service between 3 and 5 years old if they still qualify. And then once 5 years old hits, the program stops.
And how much of that is contingent on a diagnosis? Does that change eligibility?
It does not before 3. That will somewhat play a role after 3 years old. Before 3 years old, any child can, regardless of diagnosis. Yeah.
So
Go ahead.
our early intervention stream of the NDIS is under 6, as long as the child has delays or difficulties in a few different areas of development, they can access without a diagnosis. But essentially, like once they hit 6,
It's
the
like,
NDIS is like, okay, well, what's happening? And there are a certain number of diagnoses that will make them eligible for their life, which is something that has been really tricky with things like developmental language disorder, apraxia of speech, like those things are not recognized.
yeah. And you're like, that's still lifelong. Like that's still, like even though it's a communication disorder, not a medical diagnosis, it is still something that's lifelong going to influence this child. Yeah, it's tricky. And it's the same thing here. There's certain ones that qualify and certain diagnoses that don't, which is where sometimes like the conversation will happen, I think, with families in terms of like, our treatment is not going to change with a diagnosis, but your coverage of care could change. And that's why we want to like seek out that aspect and getting an actual formal diagnosis.
And what about schools resourcing? So for us as well, if we're talking about going through a huge neurodevelopmental assessment process with the family, often, if they're under 6, we're kind of good with the NDIS. We can roll with not having a diagnosis, but once they start school, getting the support from the education department, there is another list of diagnoses that will make them eligible. So without that, it makes it really difficult for the schools to put supports in place.
Yeah, it's very similar. The schools aren't it doesn't always require the diagnosis. They just want to know that there is an impact on education in some manner. And I will say that their criteria does tend to be a little bit more, I want to say like higher. That's not like the right word, but like they require more than it would in like an outpatient setting from a medical setting, because they're looking at more than just, is there a medical influence? They're looking, is there an educational impact here? So a diagnosis can help. However, I have a patient, for example, in the past who had the medical diagnosis of autism, but did not qualify from the educational system's diagnosis of autism. And so I know it seems very interesting, but so much of that was just the child over time had just learned so much about how to regulate and advocate for themselves, to where from an educational system standpoint, they were like, I don't know, it doesn't, they're not checking the boxes sort of thing, as if someone with autism can fit in a box, but that's kind of part of it.
Here, we have, obviously everyone has, the level 1, 2, 3 support levels for autism, which is another conversation, but it's possible that the NDIS wouldn't recognize level 1 as a diagnosis, that's not like an automatic eligibility. So there's a lot that is happening, I guess, around advocacy for having neurodivergence recognized, full stop. Like ADHD is not recognized at the moment. So just because you have a diagnosis doesn't always mean that it opens up access. And we still get a bit of bouncing between health, education, and disability services in terms of who's taking responsibility. So this week I've had a client who is, having some really, really significant swallowing difficulties, and the hospital perceive it to be sensory based, attributed to his autism diagnosis. But I'm having a look inside his mouth and I'm thinking, oh no, you need to go and see the ENT. So trying to get him back into the hospital system can be really tricky. So we do a lot of advocacy.
There's a lot of writing.
Well, I feel the same way as like in the community side, there's a lot of advocacy, but I find in the education systems, and again, I have not worked directly in the school system, so I'm speaking from like secondhand experiences here, but from what I understand is it's so much harder to get those types of referrals, those medical referrals, because if the school-based SLP says you should go see ENT, the school has to pay for that. So if they, and so it is very hard for the school-based therapist to make medical referrals, because if they say this needs to happen for the child to make progress in the area that's affecting their education, the school has to pay for it.
That's wild.
I'm stuck.
Yeah. And so there's a lot of red tape there. So they'll usually, like, that's where a lot of families will have the school-based services, but they also have the outpatient services. Because outpatient, I can very easily send referrals and say, go see them, go see that. But if the school-based therapist says this is influencing their speech or this is influencing their feeding, which is affecting their education access, the school has to pay for it.
Wow. We have nothing like that here at all.
So we have what's called the Child Development Service. So any child, I think it's up to 18, 16, depending on the service, is eligible for free or government funded services. And that covers allied health, pediatrician, child health nurse, all that kind of stuff. So you can, and also medical services as well through the public hospitals. So you can access theoretically all of that for free, but our wait lists at the moment are, I think, sitting at around 2 years for even for early intervention. So often, if they can, families will opt to go and see a private ENT, for example. Yeah, we're in a bit of a pickle at the moment with access to pediatrics, especially
in Perth.
I've heard that about. I've heard other countries that have more of that. Oh my gosh, I'm like blanking on the term. Universal healthcare. I've had in Canada, I've had therapists speak the same of like the access, like it's like 2-year wait lists. And you're like, well, they're 6 months old. So in 2 years, it's not really going to help what's going on right now. And so a lot of people will like cross the border from Canada into the US and just pay cash for somewhere because they just, otherwise they're going to be waiting for a year plus.
Okay. A lot of our pediatricians will prioritize the bulbs. And
it really should be. I mean, there should be somewhat of a hierarchy, but that's also hard for the families that have been waiting so long.
But then the 8-year-old looking for an ADHD diagnosis might end up waiting quite a while to see a pediatrician. Okay, I want to ask you about service delivery, because you were saying for the threes, like we're talking about wait lists and like having trouble accessing services. The flip of that, my question is, you were saying that it's up to the therapists. They can kind of say, this is how much therapy this child would benefit from, and they'll get funded for that. What's preventing over-servicing?
Yes. So there are people that have to approve it. So that's why I say you have to justify. You have to justify why the child needs typically 1 visit a week. You're good. You're golden. You're probably going to get that pretty easily. If you go in to 2 to 3 or more, you're going to have to justify it. So for example, I could justify a patient with childhood apraxia of speech getting 4 to 5 visits a week because the literature shows more frequent speech therapy services is what's going to benefit. And to be honest, I cite research in my reports to show why a child needs a certain service a certain amount of time. The other thing is like certain changes to care might show why we could prove it. The biggest thing is you just have to justify it. Now, with that being said, I've had one denial before, and the denial actually wasn't feeding based. It was speech based. And they said, it was a child who had an AAC device, and I was requesting speech therapy services, for the AAC device. And they denied it because they said, why would a child need speech therapy services if they're non-speaking? And I was like, that's literally why they need it. I'm sorry. Who just read this request? Who are you? Because absolutely not. Now, when there's a denial, you can go back and say, hey, let me talk to you about this because let me explain it. Unfortunately, this ended up being one that the caregiver had to appeal. This is also a child who had like a medical diagnosis, like a genetic diagnosis. They had like, there's no way they should have been denied it. And they did end up getting the services. But usually it's just, if you don't show why it's medically necessary, then you might get denied. So you do have to go for like authorizations. Now there's some insurances. So like just regular old Medicaid, a lot of times is just like, go like, just as long as we're seeing progress on their progress reports, like you're good to go. But other insurances are a lot stricter.
Okay. How often do you have to submit a progress report?
It depends. So technically with Medicaid, state dependent. So Medicaid is like the state funded insurance. So this is based on income. So depending on the state, but for example, with like South Carolina, like technically I don't, like once a year, but there's other insurances that are like, we will give you 4 visits. And so I'm basically submitting a progress report after like 2 to be like, I'm going to need more than 2 more. So it really just depends on the insurance a lot of the time. I would say on average every 3 months for most insurances. Now, with that being said, for example, Medicaid doesn't require it, but every year I will still do a progress note every 3 months. So regardless, I want the progress note and I want to share the progress with the family in terms of like what exactly is going on. So
we have a system called Medicare. So that's our national.
So we have Medicare too, but that's only after age 65. Medicaid.
Okay. So Medicare is everyone, and there are some allied health services that you can get a rebate for on Medicare, but
to get private.
You go to a private clinician with a referral from your GP, and they say, in a calendar year you can have, I think it's up to 5 allied health. So you might have 5 speech pathology or 3 speech and 2 OT, and we have to report after the first and last session. But I don't think I've ever had a private client who after the 5 sessions, I'm like, cool, you're good to go. So
that's in a year. That's for a calendar year. That's not a month.
They can still access services, but then they would need to use their private health insurance or pay privately.
Okay. That makes
just like getting a little bit of money back, just to say like, thanks for not blocking up the public health system. Thanks for going privately.
I think that's pretty, it's like somewhat similar to our like private health insurances. Like private health insurances are like, you actually do the opposite. So you pay until you hit your deductible and then they'll cover it. So you do the pay. And then depending on your plan, it might be like, oh, you pay. And when you hit your deductible, which might be like $1,500 or something, then they'll cover 80% of the rest of them. Or some insurance will cover 100% after that point in time. It just depends on your plan, but you're paying like every month to have the insurance plus meeting the deductible. So even once you meet the deductible, you still pay every month to like maintain your insurance.
We have the Medicare threshold as well. So I think it's like $1,500 and then they pay.
Okay.
Our private health insurance, like anyone can sign up for it if you have the resources to pay your monthly premium, and you have like an annual limit on how much they will cover for a particular service. So I might have $350 of physio rebates available on my level of cover, but that will be taken up in 60% of, they'll cover 60% of my session fees until I reach that $350 cap.
Okay, got it.
And then
Yeah,
I have to
ours
wait
is-
till the next.
So the
Yeah.
like the caps, or like we call them deductibles, comes from every health service. So it's not like you have to reach 1,500 of Allied. It could be like you have surgery and you met 1,500 and everything else medical is covered.
Yeah.
So it's not like very specific necessarily. There might be like slight variations in like the percentage covered after you meet it, but your deductible is just like anything healthcare related can go to that deductible.
I'm interested as well in autism assessment because I'm in that world here. How do families access assessment in America?
Yeah. So it's similar in that like it has to be someone who is trained in it. And that is usually a psychologist or a pediatrician, or it could be a speech language pathologist. Some states don't allow SLPs to do the diagnosis, which is a conversation in and of itself. But most of the time it is a developmental pediatrician or a psychiatrist or psychologist, but it is pretty intensive testing. So most people will use like the AUS. I'm sure are you familiar with that?
Yeah.
Okay. So a lot of times it's something like that but I will say like I feel like there's more and more people getting trained in the assessment because the wait list to get an autism diagnosis is just like unbelievable. I mean, I don't think I've had a family wait less than 6 months, though I'd say on average it's close to a year.
Yeah, that's pretty similar here, to be honest, depending on which system you go through. And
Yeah.
our states have different requirements for who's involved in the assessment. So you want to be pretty careful that you've got that so that at the end of the assessment, it'll be recognized by the education department in your state.
Everywhere. Yeah, that's how, I mean, but like I said, like ours is a little bit different sometimes depending on the education system, because they'll do like a medical diagnosis of autism versus a educational diagnosis of autism, which like kind of doesn't make any sense in my brain. Like it's not like your autism just like comes off when you go to school, but I think that they're looking at does it impact their access to education versus not kind of thing.
Mhm.
That's rough on the family and the kid to kind of have to
Right.
revisit that process more. That's
And then
Yeah.
prove it.
yeah, prove your disability. Yeah.
Right. Yeah.
Gross. Yeah.
Well, and it's weird too, because like, for example, the kid I'm thinking about, like he's still qualified for services without the educational autism diagnosis. So it's kind of, I'm like, so it is influencing access to education because he still requires, yeah. Again, it's like, oh, he didn't meet like a certain checkbox, basically, is kind of it sounds more than looking at the child as
He looked the examiner in the eye once, so you know, can't tick it.
Right.
Yeah.
Yep, exactly.
I want to ask about feeding therapy. Can I ask about feeding therapy these days?
Yes.
Because sometimes I think it looks very similar to how we do it here in Australia. And then other times I get glimpses, usually on social media, and I think, oh, it looks so different to what we do.
Yes.
And Asher and I we've done our various training courses and things over the years where we've been US presenters, and definitely some of the content is very, very different to what we would do here. So I would just love to know, like, look like when you are doing some feeding therapy?
Okay.
Are you doing cooking? Are you hands-on? Are you touching their mouth? Are you sitting opposite them across a table? Are you in their kitchen together? Like, what does it look like? Because I would love to get a sense of where the overlap is.
Yes, me too. Okay. So yeah, this is super interesting. And it's funny too, because I definitely come across therapists too that I'm like, what are you doing? Like, that is not what my therapy looks like. No, so I agree, but I am curious how our practices overlap or maybe slightly differ. So, okay, I definitely take a more hands-off approach. So I am not typically putting my fingers in a kid's mouth or anything like that. I also I'm so sorry to all my physicians that I work with, but if I'm concerned about something going on, like from a tonsil standpoint or something else, airway related, and I'm like, gosh, it would be great if I could look in there. If that child's orally aversive, I'm just going to make the referral and make them hate the doctor because I need a trust and rapport with them. So
Me
like, I'm
too.
so
Yeah.
sorry, physicians, but I ain't getting in there. I'm concerned. I haven't even looked, but I would love for you to take a look because I am not ruining the trust that I have with this child. So I'm always like,
Yeah.
I'm so sorry to you, but I'm not going to ruin that for me. And so that's kind of that's a big one for me. I always compare that. My like justification of it is do you all know who Brene Brown is? Is that universally translatable?
We love
Okay.
Brene.
She's so great. Brene. Love her. I love her take on building trust with like the jar of marbles. So she talks about when you build trust, like one marble goes into the jar, but if you lose trust with someone, a whole handful comes out. So I always think about that with every patient that I'm working with, because if I've built up trust and then I put my hands in their mouth because I really just want to get a look-see and I lose that whole handful, well, we're back to ground zero. Sometimes we're negative marbles now. And like, was that really worth it? So from a hands in their mouth kind of standpoint, I am pretty hands off. Most of my sessions are coaching a caregiver on how to respond and how to support the patient. I'm usually sitting there. If I am, sitting with the patient and stuff, I try to have like food on my plate as well. So it looks like I'm just engaged in the meal time with them. But for the most part, it's a lot of parent coaching, which is why I also feel like telepractice is also very effective for my approach of feeding therapy, because I usually am not super hands-on. Now, with that being said, if I'm working with a child who's more medically involved, like from an oral motor standpoint or a positioning standpoint, then it might be a little bit more hands-on. But again, very, very much like, I have a spoon here. And so even if a child has like, for example, super, super high tone and spasticity, I'll at least put their hand on top of mine and be like, okay, would you like a bite or would you not? Like, you guide me, you tell me what direction to go. And so very, very much that realm is kind of how I present my sessions. And my goal is like always going into it where the caregiver just feels like they know the strategies, they know the cues, they know how to progress on their own. I'll talk to people about, for example, I have a patient that, and I feel like I'm saying a patient, I feel like I've had so many patients like this where we've, progressed to a certain point, but maybe open cup is hard because they have quadriplegic spastic CP, and holding an open cup and bringing it up to their mouth is tough. I'm not going to keep them on my caseload for that. Like, that's a skill where I can give the caregivers the strategies. They can go and practice that. I don't need to see you every week to work on that skill. If we have everything else as safe and functional, effective and enjoyable, those are kind of my 4 like keywords I work on, then you're good. Move on, refine skills later. You don't need me. Like, feeding is not the end all be all. There's so much more to life. So as important as I think that I am, there's a lot more. There's a lot more benefit to other things in life. So that's kind of my approach to it. With that being said, there are quite a few approaches in the US that are not that. So I've had families come who have been through providers where they weren't allowed in the room. I've heard that more times than I can tell you.
That is an outlier, absolutely. For us, you just would not find that situation here where the parent wouldn't be in the room.
No, you would actually.
In speech therapy?
Yes, I've had conversations this week.
ABA though, or feeding therapy?
It depends.
I know with ABA, often the parents aren't.
Well, I was going to say it's a lot heavier in behavior-based feeding, which is like literally makes me throw up in my mouth.
Okay, we weren't going to say it, but
we weren't going to be that.
I'm going to say it.
But like you said it first, so
yeah. We've done a lot of training across all different types of approaches, and
that's been the worst.
Yeah.
Oh, it's bad.
It's horrific. And what's scary is that in the US, a lot of those practices are children's hospitals. Really quickly, just want to give a content warning that we're about to talk about some feeding practices that may be difficult to hear. Yeah, most of them are. And they're like, we're this multidisciplinary team. I one time had a patient, I'm just gonna tell you this story because this one gets me heated. So I had a patient who went to this multidisciplinary program through a children's hospital. It's like, we're multidisciplinary, we'll rule out all the things. They primarily just saw a psychologist and an SLP. Mom was not allowed in the room. She wasn't allowed to enter the therapy room until the child accepted bites from the therapist. Then they would bring mom in to teach her the strategy. She secretly took a video of the session because she wasn't allowed to have her phone out, like no pictures, no videos.
Ooh.
Yeah. And she secretly took a video one time because she was behind like the mirror glass. And literally it was escape extinction. So it was non-removal of the spoon. So here's the bite. The kid is like turning away, doesn't want anything to do with it. If they didn't take the bite within like 10 seconds, they would ignore the kid, represent it. When he took the bite, he would have 5 seconds to swallow the bite, like literally hit a timer. If he spit it out, they would re-scoop it and put it back in his mouth. If he did swallow, then it was like they had this like toy that they were like, yay, great job for like 20 seconds. Ding, did the same thing again, had the timer, had the bite. This kid came to me and immediately I was like, what they ended up doing when they discharged from this intensive feeding program, they basically had like a oral motor tool, like specifically it's a tool that has like this like squishy knob with I don't want to say like the name of it, but like little spiky things on it, whatever. It's an oral motor tool.
Yeah.
And they would put it in puree. They would hold the top of his forehead, wipe it on the back of his tongue, and he would have 5 seconds to swallow. He had delayed gastric emptying. They never investigated that. He was vomiting 3 or more times a day. That's why he wasn't eating. Yeah. And he had been through 8 weeks of that therapy.
Wow.
And this was like not long ago. Like this was, yeah. And always like parents are like, it was horrific. I hated it. But they have all these professionals telling them like, this is great. Oh my gosh, he did so awesome. And like, I get so heated. I feel like my face is getting red. I'm hot.
Yeah. Okay, so you can't hear this if you're just listening to the podcast, but we are in shock.
Yeah.
Outrageous.
See the responses. I'll watch it on YouTube and you'll see the actual response. Yeah.
There is so many curse words I want to use right now.
I know.
That is so here, that would be illegal.
It should be. But see, this is
practice.
What's frustrating about this is the literature, and this is where I get frustrated, is the literature shows that this works, right? It gets the child to eat. I'm like, so does Stockholm syndrome. Like that also is a thing. That doesn't mean it's okay.
Torture works. Torture's a great
Right.
way to get people to
But like
the thing.
long term, what's happening? Yeah, no, and that like that.
Yeah. See, I said to you last week, I really feel like, I don't have a lot of dishes to do in clinic at the moment.
Yeah.
Because I'm not actually doing a lot of sessions where we are working with food when the families come to see me. I feel like I'm doing more phone calls every week to say, how are things this week? I call it like a maintenance phase. Like we are just going to be okay with how we are at the moment. Our goal is not to lose foods this week, or we're just working through some medical complexities. We are not even touching the foods. I'm just supporting the families through this. And it feels like, oh, am I doing my job as a feeding therapist? Isn't there meant to be food on the table in our sessions? But I'm so aware at the moment with my neurodivergent kids, my autistic kids especially, that if I push them too much, all I'm doing is getting them to mask in feeding therapy. And masking is not just social interaction. It is, I'm going to comply with what you're asking me because it gets me out of this.
I was going to say, because I want to get out.
Yeah.
But long term, there's no changes, which is why a lot of those studies that they claim why it's effective are short term. None of them look at how the child is responding in another year or 2 or 5.
Yeah. Actually, am I allowed to like cross promote here? But
Do it. Throw it out
I
there.
write. Okay, so I am lucky enough to be a writer for the Informed SLP.
Yes, you can throw them out there. Love the
I
informed
feel like
SLP.
I mean, I figured you'd be happy to have them mentioned because I know you love their stuff too. But yes, I write for the Ped Med section, and yeah, reviewed this excellent systematic review article looking at the use of ABA and behavioral therapy for teaching chewing skills in particular. And there was this great line in it. And basically, it was that the behavioral approach is excellent at teaching compliance with an activity, but not the functional skill.
Yes. Oh, that's such a good line.
And that's exactly what they're measuring.
Yep. Yep. They are. That's why I'm like, yeah, I mean, it works at what you're trying.
Works.
Right. But like define success, define works, define effective. What are you
Compliance means
Yep.
Yeah.
Yeah. Strap me in a chair and tell me I can't get out until I take a bite. I'll take a bite.
Effing head down.
Holding it.
That makes me angry.
I know. And then meanwhile, like the child had delayed gastric emptying. Like nobody was like, maybe he's refusing because he's throwing up 4 times a day. No, it's all behavior. It's just
that's used so much that like the vomiting is behavioral. Like,
yeah.
Right. Well, here's my thing. Let's say a kid is making themselves vomit. Okay. Let's say they're doing that. If they would rather do that than eat, like that in and of itself is a problem. Like,
yeah.
Okay, let's say it is a behavior. Like that's also
let's take a step back. Yeah. I do feel like that is something that we do quite well here, is like, well, I think we do anyway, is not launching into a particular type of therapy until we've done a really thorough evaluation. I think we do that quite well. Like we are making referrals off to ENT, to gastro, to pediatricians, and often a lot of the time, like we're not going to jump into really like, I guess, volume-driven outcomes or variety-driven outcomes until we know that that child is, I guess, has the foundation to participate in that, right?
Yeah, and so then we're working on things like just maintaining a positive relationship with mealtimes.
Yeah.
Even if they're not actually eating, but just that like being around food is okay and doesn't have to feel scary, or being able to like watch mum eat. And they can cope with that, and that's going to be all right. So,
or they've got some sort of control over the way the food arrived at the dinner table, or the way that they arrive at the dinner table.
I think autonomy is really pushed here.
Like,
around
I think that I definitely think that is where a lot of feeding therapy is headed in the States. And I think that I would like to say, I don't want to say majority because I can't speak for the majority, but I know an abundance of therapists, which, you know, obviously I have my own bias. That's who I surround myself with, is responsive in nature and wants to move toward that direction. But unfortunately, there is still a lot. And like I said, majority are out of children's hospitals, which is the places I think parents assume they could trust the most. And it's not all children's hospitals. There are some really great ones. I think it's kind of like a authoritative bias that comes into play there. You assume that would be the biggest authority and be the best option. And unfortunately, it isn't always.
And I can see how it's happened, right? Because there is a lot of research behind the approach. Like behavioral studies have been around for decades and decades. It's some of the oldest research that you can call upon. And because they do write it so it sounds like it's working.
And it sounds like it's
evidence-based, right? The hospitals will say, we want to use a program that works. And so then they look at the research. Apparently it works. And so then that's what they do. Like, I don't think that, I would hope that they're not like intentionally going out of their way to run programs that are damaging, but
it's all
down my back.
It's all in the outcomes, isn't it? Like what are you measuring?
Well, and you look at if you look at some of the websites that like promote these, they say like 98% of patients leave taking 50% more by mouth. 99% of patients leave. And it's like, but what are they enjoying taking it by mouth? How are they taking it? Is it a tool that you're wiping on their tongue? Does that really count? as oral intake. Like, so they place these stats that again makes it seem like their program just has it together. I've seen multiple children that did like a tube wean through one of those intensive programs, and 6 months later, they're back on full G-tube feeds because anything that was gained was because I just want to get out of this situation, not because they actually learned the skill, which goes back to what you just said, Holly, where it's like, it's teaching compliance. It's not teaching a skill. It's not teaching what they're actually trying to achieve.
And these kids have enough medical trauma to deal with, let alone therapy trauma on top of that. Like I see a lot of medically complex kids as part of my caseload, and it's real trauma.
Yeah.
I can't imagine then. And then it makes me angry that the parent is then expected to continue to perpetrate that experience onto their child. That is so irresponsible and awful to affect that attachment relationship. Like, I mean, imagine, like, so your parent, your mum for that child is supposed to be the person that you turn to in a time of fear and worry. But then suddenly the thing that's giving you fear and worry, the food in front of you, you turn to your mum and she's the one giving it to you. Like, that is so confusing for a child. It's so disruptive, deeply disturbing for that relationship. I
know it breaks my heart. Which, I mean,
deep breath.
I think that's as it's horrific to even say, but that is why they don't allow the parent there in the beginning. Because the parent is the safety net, and the child's going to be looking at them like, please save me. They wait until there's some compliance before they bring the parent in.
And I think another thing that we reflect on is when you have manualized approaches or programs, it's much easier to communicate those and train people in them when there is a set number of steps and you have to do it this way. So I can see from a commercial perspective as well that we've ended up with all of these options and programs that then have their own evidence, because that's how you sell something. You package it up and it's it's easy to digest for a therapist who wants to feel like they're doing a good job.
That's what I like about your stuff, Brie, that you put up on your Insta page, for example, is that I love how there's so much nuance in what you talk about. So even when you're talking about the controversial stuff, the things about tongue ties or cups or whatever it might be that you're chatting, but I really appreciate that you bring nuance into it instead of that kind of black and white thinking, because that's the tricky bit. So in Australia, I do, and Asher as well, do training and mentoring and stuff for working in feeding therapy. And so many times my mentees will say, like, oh, I saw this thing on Instagram, right? Like, I saw this infographic, I saw this meme, I saw this page, whatever it might be. And the stuff that sells is usually really black and white stuff, because you go, oh, this is the answer. Like, this is what I need. This is what I'm missing.
And they present it as fact-based. That's
like, here's the solution to your problem. I want that. But when you actually, but then my mentees will say to me, but I feel like there's something missing, right? Like, I get it, but like, what about this? And so then we have these great discussions, which is excellent. I love my mentees. They're very deep thinkers. But it bothers me that it's out there, all of this really fact-based, black and white information being put out there, when so much of what we do is problem solving and really looking at the grey in situations.
And being able to synthesize information from a number of different sources to inform your approach. And and also I think the thing that drives the changes that I've made recently over the last couple of years is values driven as well. Like, me as a clinician, as a person, when I sell a service to a family, I want it to be driven by my values. And that is a lot about now a child's relationship with food for their life, and also the relationship with their family and what the experience of eating in mealtimes is like. And that's not just about the bites that you're taking. and I don't want to be a person that, creates more stress for a family.
Yeah.
That's not what we're here for.
It's interesting you bring that up, because I had a conversation with a student, one of my undergrad students, over the week, where we were talking about, like, has a family ever said, I don't want, have they ever just said, I don't want feeding therapy from, or I don't want therapy from you, or I don't like you as a therapist, like those types of conversations. And one time I had a family who, after the initial phone call, did not want to work with me. And the reason was they were fully convinced that their child had ARFID. Now that's a whole it's a whole discussion for itself, but this was a child who was 2 years old, and they were fully convinced it was ARFID. And I said, my approach to therapy is that we make sure we've ruled out other medical diagnoses, we investigate, and going through that. And they were just like, we're not interested in other referrals. We just want behavioral feeding therapy. And I said, then I'm not the therapist for you. And like, that goes into, though, the value side. I'm not going to push any type of therapy on a child unless I know that they are safe and comfortable. I just am not. And so that's like the one time it's come about where they were like, oh, we've been seeing this psychologist, but like we're doing cognitive behavioral therapy, but it's not helping. And I still am in the back of my head, I'm like pretty convinced this child had EOE, like eosinophilic esophagitis, because they would take tiny bites of everything, chew everything for a long time, but would drink anything. But a psychologist diagnosed them with ARFID, and they were like, that's what it is. And I'm like, no. Like, have you ever seen a GI? And they're like, we're not interested. Actually, what they told me was, my husband's a head and neck surgeon. I think he would know if my kid needed to see a GI. I'm like, that's not really relevant, but anyway.
Yeah.
Thank you for sharing that.
Thank you so much for sharing that. But I still think your child should see a GI. But that was like an example of like a value side where I was like, if you come to me, this is how I will approach therapy.
But that's the therapeutic relationship, isn't it? Like that's where the magic happens. It's the old, like, what we do is science, but actually what we do is an art. Like, what we bring to the relationship is what makes the difference. Otherwise, the parent could just go off and read a book or watch a YouTube video, or
right. Like the science gives us the foundation, but we ultimately have to then kind of, like you were saying, Asha, like synthesize it and then apply. Like you have to finesse, because there's so much nuance. I think 99.9% of what I do is that gray area. Like
absolutely.
That's majority of it, for sure.
And then making parents who want black and white answers feel it's okay to sit in the gray. Like, it's okay.
Yes.
Yeah.
And there's also a lot of reflection required for yourself as a person. Like, you're not just coming into therapy as a therapist, like you've done your qualification and now I can just apply everything as it's meant to be. Like, you're bringing your own personal experience and your own experience with food and your own experience with how you were parented in your meal times. And often, I mean, that's certainly something that I wasn't thinking about with an awareness as an early career speech pathologist, but being able to get into a space where you can acknowledge that with families and you can ask them what their experience was, the parents, it's so much easier to build that relationship with them when they can see that you are considering them as a person and you're able to acknowledge how your own experiences show up in feeding therapy as well. That's super important.
Yeah, that's a great point. I think a lot of that goes into that, like, culturally responsive therapy. And that's kind of where I know I make some people mad on Instagram when I talk about, like, I don't care if you watch TV during the meal. Is that how your family eats meal times? Or like, I don't care if you sit at the table. Do you all sit in the living room and eat dinner? I'm not going to force you to go to the table. Like, what is your cultural norm? Like, what happens in your home? That's what I care about. Like, trying to force my idea behind what a meal is supposed to look like isn't going to help anyone.
Standards or whatever. I even, like, basic things. I had a family not so long ago, and like their OT had recommended a high chair for their little guy who needed a lot of extra supports, like supports for meals. And the dad was saying to me, like, this is not going to work for us. And I'm thinking, well, this is like, they recommend like a beautiful high chair. It's gorgeous, you know, like all the right padding and everything. And he's like, no, we sit on the floor to eat. It can't be up in a high chair. It's going to be like a meter and a half off the ground. I need my kid down on the floor where we're all sitting. So that was fine. We went off and found a high chair that could be down at floor height. On the floor. And like it was no, but it's just considering asking like, what does it look like actually, what does it look like, and where in the house are you, and are you even all sitting together at the same time, or is dad actually at work in the morning and the big brother is serving up breakfast for the little brother, and mum is, you know, getting ready for school for the kids,
and what would make the biggest difference for you in the context of a mealtime? Not, you know, okay, how do we get everyone at the table at the same time, you know, perfect positioning, perfect nutrition, how do we work towards that? It's actually like, what can I do with everything I know and everything that I've worked to accumulate in terms of knowledge to make this better for you?
Like what actually matters to you? What is the part that would make that difference there? It's a great point. I always present to my families. I always say, like, anything that I say as like, I would recommend, or I think we should, whatever, is a suggestion. And if it doesn't work for you, I'm like, literally be like, Bree, thank you so much for that. Not going to work, because my job is to critically think through what will work. Like, I have tons of things that I can throw at you, but don't just say, that sounds good, if it doesn't actually sound good. Like, there's that two-way piece too, and kind of opening up that discussion. I'm like, all right, what do you think about, you know, let's try this. And it's like, don't nod your head at me and say, okay, sure. If you're like, no way in hell is that going to work for me, Bree, but thank you so much for that. Like, let's try something else.
I have been saying to families recently, you know, I'm going to give you this, you know, write-up of what you found most useful from today. But if you come back next time and say everything went really well, I'm going to be suspicious. Like if that was how simple it was, you wouldn't need to see me. And I know that you have already tried everything that you can think of to make this situation better for your family. So I want you to come back and tell me.
I love
that didn't work.
I love that. Like, I'm going to be suspicious if it all works. Well, it already, like, I was just going to say, that just opens up the discussion of what didn't work. You know, it makes the family not feel like they're going to like hurt your feelings by saying something didn't work. You're like, I expect something not to work, so tell me which thing it is.
Absolutely. I worked with this amazing OT years ago when I first started in feeding. Shout out to Jill Griffiths if she's listening. Hey, Jill. And she was a big advocate of basically helping the family to fire you. So basically getting them to a point where they don't need you anymore. And her big thing was always that you get the family to be the problem solvers. So she doesn't even offer strategies and suggestions. She will support the family. And so she does a lot of wondering. So like, I wonder what would happen if, or I wonder what you're thinking is going on here, or I wonder why that mealtime went so much better. Like, you know, when the family comes in, they say, they actually ate a new food this week. Like, they ate pizza. And so rather than be like, oh my gosh, that's great. Okay, well, if they're eating pizza, let's get blah, 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 blah. She would say, like, I wonder why. Like, and she would just leave it open. So she wouldn't even offer what her thoughts were initially. She would just wait for the family to offer up their suggestions as to why they think it worked. And so her whole thing is to try and pivot the relationship around so that the parents are starting to reflect and problem solve. Because then if they can come up with the strategy themselves, if it doesn't work, it's not our fault. And so that external locus of control is not as obvious. It's not like, well, the therapist told me to do this and it didn't work. There's much more impetus for change if it's something that you have decided that you think should be done. So so that's, I think, also ties into this, like,
helps with, like, that's also probably helps with a lot of like buy-in and like wanting to try it, because they're like, I truly think this is gonna work. I feel like that is very similar to a lot of parent coaching approaches too, of like, okay, so like, I've helped, you know, we've problem solved through some things, but now what do you do? But I love that of like,
Mhm.
oh, wonder why, wonder
Yeah.
what would happen if we then, or
Yeah.
Yeah.
Is there anything else that you wanted to capture before we finish?
I want to start doing with guests like a rapid fire thing. So I'm just going to ask you like 3 questions and just like tell me off the top of your head. So let me pull up my questions really quick.
Ooh, okay.
Not to put you on the spot.
But that's exactly what you're doing, actually.
Yeah,
So
that's what rapid fire
That's,
means.
I am. I know, I was about to say, not to put you on the spot, but to put you on the spot. So really quickly, I'm going to give you just 3 rapid fire questions, and it's meant to be rapid fire. So I want you to answer in like a word or just a couple words or a sentence. It's not meant to be like, don't elaborate very long. Just like, what is the first thing that comes to your head? Okay. All right. So the first one is, what is one thing you think all feeding therapists should know?
Attachment theory.
Oh, good one. Responsive feeding.
Okay. Love both of those. All right. What is your favorite thing about feeding therapy?
Snacks all day.
Babies.
And babies. I love it. All right. Your last one, and this one's kind of a little bit more fun. What is your favorite food to use in feeding therapy?
Oh, for what? Oh,
So what's your what's one food that's just like a go-to? You're like, oh, I'm working
Chicken
on
crimpies.
I don't even know what that is.
okay.
It's a cracker. It's a delicious cracker. Chicken crimp. I don't even know why I said that. I mean,
That's so random. Out of everything,
what are you? You haven't said a word, so
I can't. Oh, freeze dried fruit.
Ooh, all right. Okay. These are good.
Yeah.
These are good.
I'm gonna
I
stick
love
with
it.
chicken crimpies.
I feel
Yeah,
like
I
both
can-
of
I
you
can see
are
that.
thinking like you're gonna pick a food to work on like chewing. Like that's where like my brain went a
No,
little.
no, mine's not chewing. Mine is like
Variety.
make a juicy, scary thing less scary as an intro.
Mine was just because it's delicious, and if I have to eat something with the kid in the room, I figure I might as well pick something tasty. Like
That's where my brain went to initially. I'm like,
like-
what food do I like to eat with the kid?
Yeah.
Oh, okay. Well, if that's it, then I'm going Nutella bagels, obviously.
Now we're just sharing like favorite food overall. So
or yogo.
I think you should. One of the rapid fire questions should be, what is one food you hate working on in feeding therapy?
Yeah.
okay, throw that in there.
I have a blanket, no bananas. Bananas make me gag, and I will not. No thanks.
Mine
What's
is
your
fresh
top?
blueberries?
Fresh blueberries. You won't do it.
No, thank you.
That is so
Really?
funny. That's so
I
funny.
didn't know that about you.
See, I don't eat red meat, so that's my thing. The family wants to
Oh,
work.
I'm vegetarian. Yeah, so yeah, that
So
makes it
those
tricky.
are. But here's the thing: if a kid is working on it and they hand me a piece, I'm gonna chew my way through that piece of food. I'm gonna do
Yeah.
it. I'm always like FTK for the kids. I can do it. I can manage this bite of food. Those are the only ones that I'll do it for.
Yeah, that I feel the same way about concoctions that kids make. Like they've made toast or a sandwich that they're really proud of, and they offer me some. I'm like, thank you so much. I would love to try this.
Yeah.
Oh,
Because
Yeah, and it's like
do like
yogurt.
one bite and then you're like, I'm just so full. Oh,
Yeah.
oh, I'm just
I'm listening to my body, and I
Yeah.
feel full. But thank
I'm
you so
so
much.
full. Yes, I
I'm
love it.
full
Oh
of
my-
this food.
Yeah.
The worst
Oh.
I had was vanilla yogurt with apple juice mixed in and sprinkles,
Oh,
and then fruit puree. And
Oh.
he was eating it, and he was liking it, and he had never eaten fruit before, any fruit flavors.
You're just like,
And so Mum and I were like, hooray! And then he wanted all of us to eat it. My gag reflex has never worked so hard in its life to dampen off. I was like, just,
yeah. You're just like, I'm in another place. I'm not here right
Yeah.
now.
yeah, I am in a happy place.
this is the food that I am learning about.
Yeah. This is also your therapy time.
learned to eat a lot of foods actually as part of feeding.
Yeah, I've also tried a bunch of foods from cultures that aren't my own, and that's been really
Yes.
cool.
That is one thing that's very enjoyable, is learning about a lot of different foods, for sure.
Yeah, being swear words in other languages. I learned that couscous is a really dirty word in Dari. Yes.
Would have never known.
And so I recommended to a family, I was like, oh, maybe you could try like adding in some couscous to the
And they were
puree.
like,
And the dad was like, and it's like, first, it's a rude word for female genitalia.
Really?
And you're like, so don't try that.
Maybe don't be doing much with that one.
So funny.
All
right.
Anyway.
Well, I appreciate you all so much. This was such an awesome conversation, and it's been fun to learn about some of the similarities, some of the differences, and be able to chat through that. So thank you so much for hopping in.
Thank you.
Look forward to continuing to chat with each other.
Thank you for having us. Oh, how about we send you some Australian snacks?
Please send me some.
Okay, and then next time we catch up, we'll do snack reviews. Okay.
Yes, that's perfect. Thanks for tuning in to the Feeding Pod this week. If you enjoyed today's episode, please don't hesitate to share this podcast with your friends and colleagues and leave us a 5-star review wherever you're listening from. If you're interested in learning more about pediatric feeding and swallowing, be sure to follow me, on Instagram at Pediatric Feeding SLP. Or check out my website where you can get access to more courses and information, www.pediatricfeedingslp.com. Again, thanks for being here and listening to my ramblings, and I hope you'll keep listening. Until next time, cheers.